Gang, our final tape for today, we'll do some malformations and developmental disorders first. These are pretty straightforward. We got things like neural tube defects, usually caused by folate deficiency, forebrain abnormalities, and of course posterior fossa abnormalities, and then finally spinal cord malformations. So let's get right to it. Neural tube defects, most students should know this already. Neural tube defects account for the most of CNS malformations. There'll be other ones in the forebrain and cerebellum too, but these are the most common. Now, they usually involve the spinal cord, although you do have anencephaly too, but most of them are in the spinal cord. Now, they're caused by defects in neural tube development. So either I didn't close it, or I did close it, but then it opens up again. So in either case, it's a problem with the closure of the neural tube. Now you have two ends of the neural tube. We have the cephalid end and the caudal end. If it doesn't close up here, you get anencephaly. If it doesn't close down at the bottom, you'll get problems with the vertebrae, spina bifida, meningocele, meningomyelocele, and so forth. So it really depends where in the neural tube is the opening. Where does it close properly? Now, a known risk factor here is folate deficiency during the first few weeks of life, first few weeks of gestation. So this is clearly associated. This is a risk factor for getting this disorder, folate deficiency in a pregnant woman early on, because this is going to affect the cell division during a very critical period that corresponds with the closure of the tube defect. So, it corresponds to the closure. So if you don't close it because there's a defect in cell division, you don't make enough cells, you can't close it, you leave it open. That's not a good thing. Now, question. What should women do then to prevent this? Well, they should take prenatal vitamins with folate, right? Here's the problem. When this occurs is before you know you're pregnant. This occurs in the first few weeks of gestation, before your pregnancy, before you get morning sickness, before your pregnancy, before you miss your period. So here's the problem. Once you're pregnant, you start taking the prenatal vitamins. It's too late. It's too late. So the rule here is we should be giving prenatal vitamins to reproductive age women who are not protected, right? If you're having protection, you're probably not going to get pregnant. But if you're not protected, then you should be taking prenatal vitamins because you don't know. You can't wait until your pregnancy tests positive because it's too late. The neural tube defect will have already occurred by that time. So giving reproductive age women in their reproductive life prenatal vitamins all the time. That's the only time it'll be effective. If you take it after you're pregnant, it's too late to prevent a neural tube defect. You got to take it all the time. All right, now to make this diagnosis, we can diagnose it before the baby's born by imaging to see the neural tube defect, or by doing a maternal screening test, looking in the maternal serum for elevated alpha-fetoproteins, and not just alpha-fetoproteins. Also, acetylcholine esterase will also leak out as well. Any open neural tube defect, both of these are going to leak into mother's blood, and we can measure it. Usually this is done in the second trimester. We look at this. So don't miss it. There's two things. They'll ask which one you don't know. So everybody should know alpha-fetoprotein, but acetylcholine esterase goes up as well. All right, now here are some of the neural tube defects. Again, at the caudal end, the lower portion, you can get spina bifida occulta. Okay, spina bifida, bifid, there's two. Remember, the vertebral body is supposed to fuse. It's supposed to fuse, and inside is your spinal cord. Your spinal cord's on the inside here to be protected by the bone. Well, spina bifida means didn't fuse, it's open. So the vertebral body is now open. It's open. Okay, that's spina bifida. Now it's occult. It's occult because the spinal cord and meninges is still inside. The clue you may get is a dimpling or a small tuft of hair on the lower back. So this lower back area, now this has been opened here, but you can have a dimpling, a depression with some hair. That would be classic. Now, good news, it's usually asymptomatic because the spinal cord is still inside. It's still inside the bony. It's open, but it's inside. Now, when things start hurting through that defect, that's when you're going to get symptoms, especially when you have a meningomyelocele. Okay, meningo is meninges. They come through. If they're the only thing that comes through, you go to meningocele, just meninges. But what the spinal cord comes to, that's myelocele. So meningomyelocele means the meninges and the spinal cord are now outside of the protective vertebrae. That's not good. You need the vertebrae to protect your spinal cord. If not, you can have a lot of damage to the cord and you get paralysis and incontinence. Not good. So this is an extension of the spinal cord and meninges through a defect in the vertebral column. And it's most common in the lumbosacral region like you're seeing here. So you got this defect here. Now you're going to get defects of motor and sensory function in the lower extremities because down here, the upper extremity nerves have come off already. So now you're only left with the lower extremity. And of course, also bowel and bladder incontinence, which is very common in this as well. In fact, this is very sad. I mean, if this baby rolls over, and they'll compress their spine. If you tap and say, baby, you want your burp, you just paralyze the baby. So this is not good. We're going to need neurosurgical consult to get in here and put this stuff back inside. Got to protect it. If you don't protect it with vertebrae, it's going to get injured. Okay, now, if the neural tube doesn't close up here in the cephalad end, you're not going to have a brain. It's not going to form. So that's called anencephaly. This is absence of the brain and the skull, and also the pituitary too. So pituitary, brain, and skull is all missing. Now, can you live without a brain? Some of my friends act like they have no brains. But no, you need a brain. You need a brain. So no brain, this is incompatible with life. Now question, on the ultrasound, what am I going to see on ultrasound? Well, you'll see there's no skull, there's no brain, there's no pituitary. But what else will you see early on? Well, polyhydramnios. You'll see lots and lots of fluid. Two reasons. Number one, without the pituitary, there's no antidiuretic hormone. So the baby's going to pee like crazy. They're going to diurese. And then number two, the baby can't swallow because without a brain, you don't have a swallowing reflex. So the baby's not going to swallow the fluid to get rid of it. So no swallowing plus lots of pee, polyhydramnios. That's a very important clue. Lots of fluid. Then you'll notice on ultrasound the baby's missing their brain. And that's terrible. That's incompatible with life. Now, what if the brain actually protrudes outside the skull? Well, that's called an encephalocele. Cephalo is brain, cele is one of these projections, right? So this is a diverticulum of malformed CNS tissue that's extending through a cranial defect, a defect in the bone. So you usually see it back here in the occipital area. You often see this big old mass there, and you're like, what is that on the back of the baby? That's some brain tissue that's protruding through this hole, through a hole in the skull. So usually an occipital or posterior fossa region. It could be cerebellum, it could be brain, but it's going to be protruding outside, which is it's kind of freaky when you see it. When the baby's born with it, the parent's like, what the heck is that? And it's brain tissue protruding. Not such a great thing to have. All right, now these are less common as compared to neural tube defects, but still important to know. Some forebrain anomalies. Okay, mega means big, encephalopathy, brain, big brain. This is you. You got a big brain. Well, no, but you're just very smart. This is actually increase in brain volume. This is having really a large brain. What if you have a small brain? That's called microencephaly. This decreased brain volume, and this is much more common. Oh yeah, well if you look at society, yeah, small brain individuals. All right, I'm making a joke. But this is more common. We'll see this with chromosomal abnormalities. You'll see a lot of people with microcephaly. So something like trisomy 13, Patau syndrome. You can see this with Cri du Chat. You see these small round heads. You can see it with fetal alcohol syndrome. You can see it with in-uterine HIV infection. So it gives you dementia, but it also can give you small brains too. All right, now lissencephaly means agyria. No gyri. Remember sulci and gyri. There's no gyri. The surface of the brain is just kind of smooth. It's just smooth. Wow. So if you look at the surface of this brain, look, it's just smooth. Where are the gyri and sulci? There should be like gyri and sulci. Let's put some sulci in there. So now you're creating some gyri. That's what it's supposed to look like. This is just smooth. So that's called lissencephaly, agyria. Now this is often due to a malformation. This is a malformation due to migration problems of the neuroblasts. So whether either they have trouble migrating in or they migrate in, they just stop. They don't stop moving, they just keep going until they get all the way to the edge. So it's migration problems of the neurons. That's why you get the flat brain. Now you get an absence of gyri, so the brain is very smooth surfaced, and these patients often have significant developmental delays, and they often have seizures as well. So I don't want a small brain. That's usually due to pathology. I don't want a smooth brain. I want a brain that's big with lots of gyri. That's what I want. More gyri, supposedly the smarter you are. Now, what about this? Holoprosencephaly. Holoprosencephaly means one hemisphere. No, you're supposed to have a right brain and a left brain. You're supposed to have two hemispheres. Well, if you only have one, that's a developmental abnormality. You only have one. So you had incomplete separation of the hemispheres across the midline. So they're basically fused into one brain. Now, if you have one brain, you often have one eye. We call this a cyclops baby. Doesn't have to have it, but they often have a cyclops baby. So they'll show you the baby. There's his nice mouth, nice nose, and they got one eye. One eye. That's a cyclops baby. Now, I want you to associate this with trisomy 13, which is Patau syndrome. So they have microcephaly and they have holoprosencephaly very briefly. And also, it occurs in Sonic the Hedgehog, because Sonic the Hedgehog pathway is important for lateralizing right versus left. So if I have mutations in Sonic the Hedgehog, I can't know right versus left, so I make one brain. I don't know right from left, so I often get cleft lip, just like Patau's. And I don't know right from left, I often make too many fingers, polydactyly, just like Patau's. So what's interesting to me is this mutation looks exactly like trisomy 13. They look very similar. They both have midline facial defects like cleft lip. They both have one brain, holoprosencephaly frequently, and they often have more fingers than normal, more fingers and toes. So they look very similar. If you think it's trisomy 13, you can't find it, look for Sonic the Hedgehog, because it looks very similar. All right, now that was the forebrain. Let's talk about posterior fossa, where the cerebellum is. Posterior fossa abnormalities. Now, we have two diseases here that are kind of opposites. So I like to think of as opposites. We have one where you have a very large cystic fourth ventricle because the cerebellum basically is not forming. So you get a large cerebellum because the vermis is missing. And then we have another one where the brain has no room, so the cerebellum goes down and crushes the fourth ventricle, and the fourth ventricle is basically obstructed. So these are like opposite diseases. One, you don't form the vermis and you get a big fourth ventricle. One, the vermis has no room and it goes down and crushes the fourth ventricle. So look at the size of the fourth ventricle for this one. Now take a look here. The central portion of the cerebellum didn't form. The vermis didn't form. So this fourth ventricle is now huge. I mean, this is a huge fourth ventricle. It's like a monster. It's like a big hole, like a big cystic space in the back in the posterior fossa. Wow. So that's a classic example of Dandy Walker. Now question, if you're missing the midline vermis of your cerebellum, how are you going to walk? Not too good. So always remember, they're going to be a dandy of a walker. They're going to be a dandy of a walker because the cerebellar vermis either doesn't form or it's very rudimentary, barely forms. So you're going to be a dandy of a walker. You're not going to walk pretty good. You're going to have a lot of ataxia here. Okay? So you're going to see what's called an enlarged posterior fossa. This posterior fossa is going to be very large. It's going to be filled with a lot of fluid because this is basically the fourth ventricle. It looks like a midline cyst. It looks like. It's lined by ependymon. It's contiguous with the leptomeninges, and it represents an expanded, roofless fourth ventricle. Yeah, because you didn't form the vermis. So there's no roof to the fourth ventricle. The fourth ventricle is huge. It's a big cystic space now. Now, unfortunately, this is also associated with dysplasias in the brainstem. That's not good. So now I'm having trouble walking, but I'm going to have brainstem problems. That does a lot of stuff. So delay in motor problems, such as crawling and walking and coordination. Yes, cerebellum, very important coordination. You're also going to get muscle stiffness and paralysis. You get a lot of spastic paraplegia. And you can get hydrocephalus because of the tremendous amount of space here. You know, hydrocephalus like crazy. And that can increase the size of the head. You get macrocephaly here because the pressure does seem to go up. All right, so that's the dandy of a walker because of a giant fourth ventricle because the vermis cerebellum didn't form. All right, no cerebellum, at least no midline cerebellum, no vermis. All right, now what about Arnichiari? Well, this is the opposite. This is where the brain has no room, so it crushes the fourth ventricle because as it grows, it's got nowhere to go. Now, there's two types of Arnold-Chiari. Type 1 is silent. You pick it up by accident. Type 2 has symptoms of hydrocephalus. So which one do you think they're going to ask about? Probably the one with symptoms. So this one, we find it incidentally. We're looking for something else and we find it. But type 2 is the one with symptoms, so they'll usually ask it. And by the way, they're very similar. Both have cerebellar tonsils going downwards. They're going downwards. And they can cause obstruction to CSF flow. So both carry. But type 2 always has symptoms. Now, here's what causes it. Faulty cranial spatial junction. English, please, Barone? Okay. Junction. The bones fuse. They fuse too early. The bones in the posterior fossa only. Remember, you're supposed to let your brain grow. As a kid, it should grow, and then eventually they should fuse, right? Here, they fuse too early. The posterior fossa, the bones fuse too early. So you have a small posterior fossa. That's the problem. The bones fuse too early. Well, guess what? If you have a small space back there, as the cerebellum wants to grow, there's no room for it. So it's supposed to, the skull is supposed to expand. It doesn't expand. So now the cerebellum's got to go somewhere. It grows downward. The vermis and also the medulla, it's going to push on the medulla. And they're going to go downward slowly over time through the foramen magnum. Remember, if it suddenly went down, that would be a herniation, you'd be dead. This is a slow growth downward, downward. Now, as it grows down, it crushes the fourth ventricle. So let's repeat. The midline cerebellum, the vermis, pushes on the fourth ventricle and causes obstructive, non-communicating hydrocephalus. That fourth ventricle gets crushed. So again, this kid is going to come in with headache, they're going to come in nausea and vomiting, projectile vomiting, papilledema. The pressure is going to be going up in their brain because they blocked it. So they're going to get symptoms for sure. Again, type 1 can have symptoms sometimes too. But in most cases, it's so mild, you just don't have any symptoms. Now, what's interesting to me about this syndrome is they often have associated lumbar meningomyelocele, which weren't good, right? Your spinal, your meninges and your spinal cord are outside the vertebrae. And it's associated with syringomyelia. That's cool. So both of these, by the way, this is not just for this one. This should go here too. They're both associated with syringomyelia. Okay, it's cool. And I list some of the symptoms. So again, you're going to get papilledema, you're going to get headache, your pressure's going to go up, you're going to get pain and numbness, and it can push on different things. You get vomiting, insomnia, you can get headaches, lots of different problems and increased pressure. Now, I want to talk more about this association. So both Arnold-Chiari can be associated with syringomyelia. So let's talk about that one. That's always a fun one for the exam. All right, let me just show you what's going to happen. Here's the Arnold-Chiari malformation. Notice in the back here, it was small. The bones fused, so it's a really small posterior fossa. There's no room. So now the cerebellar vermis is going to go downward and crush the fourth ventricle. Look, it's like a slit. This fourth ventricle is like crushed. It's like slit shape. So that's why they get the obstructive hydrocephalus. It's all about a small posterior fossa, get downward extension of the vermis through the foramen magnum. And then it pushes on the spinal cord. When it pushes on the spinal cord, it can now cavitate. That is called syringomyelia because it's pushing down on the spinal cord and you get this cavitation in the center. So let's talk about this in greater detail. This is a spinal cord malformation called syringomyelia. Myelia, this is spinal cord. Syrinx is a big fluid-filled space. So a big fluid-filled space in the spinal cord. Now, do you remember the spinal cord should have a little hole in the middle? That's called the central canal right there. Should have a CSF line, ependymal line, CSF-filled central canal, right? Well, what if that cavitates? Because you're pushing on it, it cavitates. Well, if that becomes larger, a big, larger space filled with CSF, that's a syringomyelia. It's basically central cavitation of the CSF line central canal. It's a big cavity, so it's got a lot of fluid in there. All right, now who's going to get this? Well, it usually presents as a young adult. And what they're going to get is as this gets bigger, it knocks off the crossing fibers, the decussating fibers of the spinal thalamic tract. Remember, spinal tract goes up and down, but at that level, it crosses first. So first it crosses, then it goes up and down. But it crosses at the level. So you're going to lose the crossing fibers at the level of this syrinx, at the same level. And this is, of course, pain and temperature. Spinal thalamic is pain and temperature. So you lose pain and temperature at that cord level, and most commonly it is cervical level. So where do you lose pain and temperature? You lose it right here. Cervical level means right here. Do you know where Batman's cape hangs off? You're all Batman fans. Where Batman's cape, they call it a cape-like distribution of loss in pain and temperature. So imagine, Batman wakes up and says, Robin, would you like some eggs? I'm cooking eggs, Robin. Would you like some? All right. Something's burning. It's my hand. They don't have pain and temperature in this distribution. So they're going to burn themselves when they're cooking. That's classic. They burn themselves because they can't feel temperature or pain. So they burn themselves when they're cooking. Now, what about a hot shower? Well, you turn on the shower, it's really hot, steam's coming on, you're like, I wonder how hot it is. Before I get in, I should test, right? So do you put your face in? No, you put your hand in. They're going to feel it, and they'll say, oh, it doesn't feel hot. It doesn't feel it. They're not going to feel the temperature. So they're not going to, even though steam's coming out, they'll say, oh, it's not that bad. And now they're going to get in. Now, again, you don't get in face first, you're going back first. When you're going back first, this water, hot water burning is going to hit here, and you're just not going to feel it until the water comes down here, and you're like, ah! So you're going to burn your upper back and your hands. In a hot shower, when you're cooking, you're going to burn because you're not going to feel it. Now, when you get the description, doctor, I keep burning myself when I'm cooking, you take a needle and you say, do you feel that? No, 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 no. Ow, 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 ow. No, 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 no. Loss in pain and temperature in this distribution. You immediately get an MRI. You get an MRI of the spinal cord, and you're going to look for this dilation in the cervical level. So MRI of the cervical level, and you will see this big dilated area. That's so cool. And by the way, I forgot to mention, MRI is fantastic for anatomy. So it's great for syringomyelia, it's great for Arnold Chiari, it's great for picking up Dandy Walker, it's great for picking up lissencephaly, holoprosencephaly. Now CT is good as well, but MRI gives us the best detail. So if they ask you what is the best test for all these things, MRI, great for anatomy. Now for acute bleeding, CT. CT shows acute bleeding as bright blood. So if you have head trauma or the worst headache of your life, you may be bleeding. So let's get a CT. CT without contrast, no contrast is required, that's great for bleeding. But in terms of anatomy, all right, now one more thing about this syrinx, okay? We said it was associated with Arnold Chiari. It's also associated with other things that push on the cord as well. How about a tumor? How about a spinal cord tumor? How about a hematoma? Maybe you had trauma and you have a blood clot. How about a clot? So I'm just listing some of the associations. So Arnold Chiari malformation is the big one. Most cases are Arnold Chiari associated. But it can be associated with a tumor pushing on the cord. It can be associated with trauma where you get a blood clot pushing on the cord. Anything that pushes on the cord can cause that central cavitation. Now, when it gets really bad, like in this case, not only do you lose pain and temperature, but this case is so severe. Do you see it's knocking off some of the motor neurons here? Let me just erase this. It's knocking off not only the crossing fibers, but it's getting some of this anterior horn here, the motor. So if it gets the anterior horn, now you're going to get weakness in your hand. So loss of pain and temperature, now weakness. You're going to be dropping the pans and stuff. You're going to be a terrible cook. So now you're going to get atrophy of the thenar eminence. So this big bump here is going to atrophy. You're going to get real weakness of your hands. So that's a very severe case, and that's the kind of case they like on the exam. Loss of pain and temperature, and then in case the student doesn't recognize it, they'll give you some atrophy and weakness of the hand too. Just so you make sure you look for this dilated syrinx. Okay, now next category are the CNS trauma. Head trauma is a common thing, not only in sports, but motor vehicle accidents, people get drunk and they fall down. We're going to see a lot of CNS trauma here. So very important to know these lesions. And we're going to talk about concussions, contusions, but the highest yield is going to be epidural and subdural hematomas. Bleeding in the brain is never a good thing. Bleeding the brain. So epidural is above the dura, is it below the dura? Where is this hematoma occurring? Okay, so let's go through them. Now, the first one is in the news a lot, concussions of sports players, right? Once you get it, you get more of them. You have a higher risk of getting them again in the future. And then long term, this can lead to a lot of problems long term. So this is a very controversial thing in sports nowadays, where a lot of people are having these residual problems. They can't remember. They can't remember stuff. They're having memory loss and stuff because of this post-concussion syndrome. So not such a good thing. Now, what is a concussion actually? Well, you can have head trauma, but it's a clinical syndrome where you have altered consciousness because you hit your head. Altered, you pass out, you lose memory, you don't know what happened. You lost consciousness for a short period of time. So by definition, it is transient neurologic dysfunction. So I lose consciousness. I'm playing football, I get hit, and I'm like, what happened? I don't remember getting hit. I don't remember it. I lost consciousness. I passed out for a little bit. And that's what they always ask it. Did you pass out? Do you remember what happened? Because if you lose consciousness, that could indicate it was a concussion, if you remember. They also can stop breathing temporarily. So they get a little cessation of breathing, they get hit so hard, and they lose their reflexes. Now, here's the good news. All of this usually recovers very rapidly. So within a few seconds or a few minutes, consciousness comes back. You're like, whoa, what happened? What happened? What just happened? You start breathing again, your reflexes come back, so you get complete neurologic recovery, but you don't remember what happened. Amnesia for the event. It's like they say you never see the one that gets you, right? So you go, what was the number of that truck? I didn't even know I got hit by a truck. You won't remember even getting hit by the truck. That's a concussion. Okay, so if you remember getting hit by the truck, getting a concussion. You don't remember the truck. I don't remember what happened. I was playing football and now I'm in the bed hospital. What happened? You had a concussion. Okay, and again, multiple of them, this could lead to problems long term. Now let's talk about a contusion and laceration. What's a contusion? A bruise. A bruise. So a little bit of bleeding into the tissue. Bruise. What's a laceration? Well, it could be a direct penetrating thing like a gunshot going through or a knife going through, but more likely it's from the brain twisting and pulling and tearing vessels that you get a bleed. So a laceration is a bleed in the brain. Bleed, a cut, so you bleed. Okay? So a bruise in the brain is some localized bleeding because of blunt trauma. This is due to either penetrating trauma or torsion where you're ripping the vessels and bleeding from that way. Okay, so both bleeding in the brain is different ways. Blunt trauma, and this is more of a torsion trauma, or penetrating trauma. Okay, now both these lesions are associated with direct injury to the brain, parenchyma injury. The brain got injured here. Because a concussion, at autopsy, I can't find anything. I couldn't find anything, nothing grossly. Now, microscopically, you may find stuff, but grossly, you don't see much. This, you're gonna see a bleeding. You're gonna see bleeding in this one. Make sense? So you're gonna see gross evidence that the brain was injured. You'll see bleeding. Now, where does the brain hit the skull? Well, common locations are going to be area where the brain is an overlying and irregular part of the inner skull. So some surface that's irregular, like for instance, the frontal lobes, you've got a bone right here. So part of the frontal lobe hangs over the bone, and that could hit the bottom of the frontal lobe. So that's the orbital ridge can hit the frontal lobe. So if the brain goes forward, it hits that. That's one. And also the temporal bones here too. You get to the side, your temporal bones can get bruised too. So these are areas where the skull is irregular and the bone can bump against it. Okay, now contusions are most common, contusions that occur in the occipital area where it's smooth, brainstem, which is in the middle, cerebellum. These are usually going to be associated with a skull fracture. Okay, so if you have a skull fracture, then you can get contusions in these other areas. But usually it's the frontal and the temporal, because that's where the bone is irregular. Now, concept of coup versus contra coup. Okay, coup means a blow to your head. So, coup injury. Say you're just reading your notes, minding your own business, and you're at the bus stop, and somebody walks up to you with a baseball bat and says, "Meet Lucille," bam, and they just whack you right here, right, boom, right there. You're gonna see a bruise right there, right there. That's a coup injury. So you hit my brain. My brain wasn't moving at the time. I was just standing there, and you hit it suddenly. Well, you're forcing the skull to push back on the brain suddenly. So the skull goes right into the brain. So here's my skull, here's my brain. You hit the skull with the thing. The skull comes back, hits the brain. So that's a coup. It's going to be right where the blow is. Contusion at the point of contact. This is, again, when the head is not moving at the time of injury, and then suddenly the bat comes and hits it. Okay? That's a coup, a blow. Now, what's a contra coup? That means that I hit you on this side, but the bruise is on the opposite side. That occurs when the brain is in motion. Okay, so this is a contusion that's on the opposite side of the trauma. This is when the brain is in motion. It's moving at the time of injury. So it's moving, and then suddenly your car hits the brick wall. Then your brain hits something and stops moving. So here's my brain, right? It's in motion, and then suddenly it stops. It stops. Well, that's going to hit the front, and that's going to bounce back and hit the back. It's going to hit both. So if the brain is in motion with these sudden deceleration like car accidents, it's going to hit the front, coup, and then it's going to bounce and hit the back. That's a contra coup. It's going to hit both. This also happens when an alcoholic falls. So they're drinking, they fall whack. Well, now their head's in motion, and then it gets stopped on the sidewalk. So they hit here, now they're going to have a bruise on this side too, because it's going to bounce back and forth. The brain's, it's kind of like, imagine ice in a glass. If you move the glass, the ice will go ding, ding, ding. It hits the opposite side. If its brain's in motion, it hits the opposite side. Now, again, when the brain is in motion, you usually get both together. You usually get a coup and a contra coup together. Okay? That's why you get contra coup, because the brain is in liquid, so it can bounce back and forth. Now, here's recent contusions. Notice the fresh bleeding here. Now, where are they located? Temporal. Remember I told you, temporal and frontal is usually where you have the irregular parts of the skull where it can hit. So yeah, nice temporal bleeding. See the hemorrhage? See the hemorrhage? Hemorrhage. Bruising inside the brain, in the brain. It's not sitting on the surface, it's in the brain. All right, now here's an old bruise. Notice this is on the bottom of the frontal lobe because it's going to hit the orbital ridge. So bottom of the frontal lobe. Now, how do I know it's an old one and not a fresh one? Well, fresh one's hemorrhagic. An old one is yellow and depressed. Depressed and yellow. Depressed and yellow. These are old ones. We call them plaque jaune because they're yellow. Plaque jaune. Yeah, these are all like scarred, like they're gliosis. They're gliosis and all the dead myelin, all that dead lipid from the myelin. Yeah, that's all this yellow stuff. So they call plaque jaune. That's an old one. Okay, so these are bruises to your brain. You can have a little bit of parenchymal damage. Okay, now these are bad. Epidural and subdural hematomas. These can potentially kill you. Now, these are always associated with trauma. Always. Trauma, trauma, trauma. You're going to see trauma with this. Especially epidural is always trauma. Always trauma because you need a skull fracture. So epidural has to be such bad trauma to the side of the head. It's got to be here because you got to break this temporal bone here. So it's a side of the head blow where you get a skull fracture of the temporal bones. Okay, so it's a pretty high impact. So this would be a car accident, a baseball bat hitting the side of your head, somebody falling 3 stories and landing on their head. This is a pretty big impact. Now, when you break this bone, if you break it across the distribution of the artery will rupture. And they want me to know it's the middle meningeal artery. That's the artery that's going to bleed here. And please be careful. There's going to be 3 choices out of middle. There's going to be middle cerebral, middle something else, middle meningeal. The MMA, like mixed martial arts. Middle meningeal, this is the one. Okay, that's going to cause these. Now, this blood is going to accumulate since this artery is in between the skull. So here's the skull, and then here's the dura. The artery is in between it. So when I get a skull fracture, you're going to bleed in this space. And now it's going to separate the dura from the skull because the dura should be up against the skull. Now it's going to separate it away. Okay, so bleed between the dura and the skull. All right, now clinically, when you hit your head, it's gonna hurt. You got a skull fracture, but there's often a lucid interval. That means you're still with it, and then you go into coma. There's a lucid interval. Usually it's 1 to 4 hours. That's usually how long you got before you herniate and go unconscious. So lucid interval for several hours before the onset of neurologic symptoms. Some people call this the walk, talk, and die syndrome. Walk, talk, and die. Here's what I mean. Does everybody remember Liam Neeson? He was a Jedi, Liam Neeson. Do you remember he was Batman's enemy, Ra's al Ghul, in the first Batman reboot? And of course he was in Taken. Give me back my wife. Remember Liam Neeson? Well, his wife is Natasha Richardson, an actress, Natasha Richardson. Well, she went skiing without him once, and she was skiing in between the trees, and she lost control, and she literally went head first into a tree trunk. High speed, hit the side of her head into a tree. Well, it fractured her skull. So needless to say, she stood up and like, oh, and she fell down. She's like, oh, this is terrible. Ski patrol came and said, we're going to take you down. We're going to bring you to the hospital. And she's like, no, paparazzi, no, call my husband. He'll know what to do. Just bring me to the lodge. Call my, and she's talking the whole time they're bringing her down the sled. And she's talking the whole time, got to the bottom of the mountain, and she stopped talking because the pressure had built up. She went unconscious into coma, and then she herniated and died. She never made it to the hospital because you don't have that much time. You got an hour or 2 hours, 3 hours. You don't have much time. What you need to do is get her to the hospital because this expands rapidly. Remember, this is arterial bleeding. That's high pressure. So this is going to rapidly expand within an hour or so, and you're gonna have to put literally a burr hole. You got to burr a hole in here and evacuate this pressure. And if you watch Grey's Anatomy and all the videos, and blood squirts out, no, we saved their lives. You literally have to punch a hole in there. I think isn't that what happened to McDreamy? They forgot to do a CT and they missed that thing, and he herniated and died. They forgot to get a test and check for it. I think, I don't remember. I don't watch the show. Somebody told me. But yeah, he rapidly expands. You don't have much time if you don't properly drain it. Patients die. So lucid interval of a few hours. Oh, and by the way, not only Natasha Richardson, because now Liam Neeson's like, epidural hematoma. I have a special set of skills. Give me back my wife, or I'll put a hole in you. Yeah, he's sad he lost his wife. Also, Michael Schumacher, the great race car driver. Well, he was skiing too, and he crashed, hit his head. Now he's still alive, but the pressure really squished his brain. I don't think he'll ever be normal again. The poor guy. Felt so bad for him. So I guess the moral of the story is, if you're gonna ski, don't go between the trees, or if you do, wear a helmet. Because unfortunately, 2 famous people hit their head. Actually, there's a lot of other people who've done it too. Not good. Now, head trauma or worst headache of your life, CT. No contrast is required. Acute bleeding is bright white. You really can't miss it. So just get a non-contrast CT, just a regular CT, and you will see it. Now, what shape is it? Well, it's kind of like convex, like a lens. They call this a lens shape. Looks like a lens, like in your eye. Lens, lenticular shapes, another name, lens-like, lenticular. Whenever I see a lens, look closer. There's a skull fracture in here. There's a skull somewhere in here. Oh, it looks like it might be here, depressed skull fracture. There's a skull fracture somewhere here. So whenever you see a lens, look closer for a skull fracture, because this represents an epidural. Now, what's really happening is the dura is being peeled. It's being peeled. This dura is being peeled back by the blood. So it's going to be nice and round like that, nice and round. And remember, it can't go past the sutures. So that's a very important thing. It will not cross suture lines because it's really attached very firmly at the sutures. So it can peel off in most places, but once it's a suture line, it won't cross the sutures, like the midline. Doesn't cross that. That's very important because subdurals can cross suture lines. This will not cross suture lines. Very important to know that. Okay, now, do I need a burr hole for this patient? Here's the rule. Size matters. So if there's clinical findings or you see midline shift, you put a burr hole in. So again, if the pressure's going up, it's going to give you symptoms of intracranial pressure. So if there's symptoms of intracranial pressure, you put a burr hole in. Or if you do a CT and you see this, look at the midline shift. Here's the ventricle on this side, fine. Look at this ventricle, squished, and the other part of it's like totally obliterated. I can't find it. I think it's like right here. It's like the other one's like totally squished. So you see midline shift, you put in a hole and evacuate this. So here's the rule. For epidural and subdural, size matters. For other things too. But for these, size matters. If they're big, which they usually are when it's arterial bleeding, you put in a hole. If it's small, you can watch it. It'll resorb on its own. But most of these epidural are going to be large because arterial bleeding is high pressure. Okay, but size matters, size. If they're big and giving you symptoms or midline shifting, that's when you put a burr hole in. All right, now I want to compare this to a subdural. Okay, that was bleeding above the dura. This is bleeding below the dura. Okay, and I should probably draw these out. Let me just draw this out here. So let's just draw. We got some space here. So let me just put this here. Okay, so here is my skull. So this is my skull bone. This is my dura, exploradora, D for Dora, and this is the brain. This is the brain. All right, so if you get a skull fracture, you're going to rupture the artery here, which is called the middle meningeal artery. Middle meningeal artery. So you're going to have blood here that peels the dura off the skull. You'll have that nice lenticular shape. So let's put that nice lens shape. Nice lens shapes. That's called an epidural. Epidural. Okay, now what if you bleed here below the dura? Well, that's called a subdural. That's a subdural. It's below the dura, and this is due to bridging veins. The bridging veins have ruptured. So they're usually going to rupture when the brain atrophies. Remember, bridging veins, they're in the midline, right? Midline, bridging veins. So when the brain atrophies, these bridging veins are really stretched. So the risk factor for this one is head trauma in a person who's old, because they have HIV, or somebody with Alzheimer's, Pick's disease, Huntington. Anybody with brain atrophy is going to be at risk for subdural because it's the bridging veins. Make sense? So the blood is going to be on the brain, below the dura, subdural, bridging veins. Now, what does it look like? It looks like a crescent moon. Subdural is a moon. Subdural is a moon. Epidural is a lens. Epidural is a lens. You've got to know these shapes. They really like to show these on step 1, step 2, step 3. When you do your ear rotation, they're going to show it to you and ask you what it is. You need to know these. Okay, now let's go through it. Subdural hematoma is also due to head trauma, and it's rupture of these bridging veins at the midline. And this is going to give you venous blood, venous bleeding, so the pressure is much lower here. Sometimes they're very small. And if they're small, you don't have to do anything. You just watch them, and the blood gets reabsorbed over time. So it really depends on the size here. But it's bleeding between the dura and the arachnoid of your brain. So it's bleeding between the dura and the brain, the arachnoid. So now, risk factors here. In old people, it's atrophy. Atrophy. So either just senile atrophy or Alzheimer's atrophy, Pick's disease atrophy, Huntington's disease, anything that causes the brain to atrophy, which could just be old age. That's what will stretch division veins. Now, for infants, they can also get subdurals just because the bridging veins are very thin-walled in an infant. So infants are at risk too. Now let's go to clinical. These are very common over the lateral aspects of the hemispheres. That's usually where they occur. And they're about bilateral at about 10%. So when you fall down, your brain can go back and forth, and you can bleed both sides and bleed both sides. Now there will be a lucid interval, and this lucid interval could be a long time because venous bleeding is kind of losing and slow. So it may be 12 hours, 24 hours, maybe even up to 48 hours before you go unconscious. So these can be very slow bleeds, long lucid interval. So very important. 5 little monkeys jumping on the bed. One falls off and bumps his head. Mama calls the doctor, and the doctor says, CT that little monkey's head. Get a CT. And of course, no more jumping on the bed too. But CT, you need a CT. If it's a significant head trauma, fell off the bed, landed directly on his head, mother said it was like, boom, head first, substantial, Well, now I want to do a CT. Now, what if the CT is fine? All right, if the CT is fine, I'm not letting you leave the ER. I'm going to observe you for like 6 to 8 hours because these can have delayed bleeding. It's venous blood. It can take time to build up. So I'll do a CT and then I'll keep you in the ER and observe. And if the kid is great, he's running around, he's playing, he's all good, he looks great. Now, what do? Do you send him home or not? Because they can still bleed up to 48 hours. Well, it depends. If the parents are responsible, you can send them home with instructions to the parents that every few hours during the night, you should wake up your child. Now, you shouldn't just check them because, look, am I sleeping or am I unconscious because I'm herniating? You can't tell, can you? So you can't just watch them. You actually have to wake them up. So a couple of times during the night, you set your watch and you wake up. You wake up and you wake them up. You go like this. And they go, fine, let them go back to sleep. If you go like this and they're like, bring them back in because I better do another CT. I think they're bleeding. So again, if the parents are responsible and they look good, you've done a CT, they look great, they've been in the ER for 8 hours, they look great, they're dying to get home, you can let them go home if the parents are responsible. Now, if the parents are Kim Kardashian, admit overnight for observation. Not making a joke. Actually, Kim Kardashian, I don't think she takes care of her kids. She needs her bird beauty sleep. She probably hires 10 people to take care of her kids. So if you're Kim Kardashian's kid, you're probably being watched 24/7. I think she only brings the kid in for TV opportunities, like photo ops. I'm kidding, by the way. I have no idea. Maybe she takes care of them. I don't know. All right, so lucid interval, it could be delayed bleeding. That's what I'm trying to get in your brain. Now, neurologic signs, again, it's increased intracranial pressure, just like it was with the epidural. So headache, confusion, and eventually it can basically herniate you. So you may have to go in there and remove the blood and organizing tissue. So again, you may have to do it. It really depends on the size. So if they get symptoms or there's a midline shift, you need to put in a burr hole and evacuate. Good. Now again, CT is the key here. So CT, no contrast required. Look at the shape. Subdural is a lens. See that lenticular shape? And it can cross the suture lines. It can go wherever it wants because it's on the surface of the brain. It doesn't care. It's under the dura. So it can cross suture lines all it wants. So that's a very important thing. If it doesn't cross suture lines, then you have to think about epidural. Crossing suture lines, then it's not an epidural. Now the shape is described as concave. It's like you're living in a cave. So crescent moon or like a cave shape. So that's concave, like you're in a cave. So that's the classic appearance. Now for this one, would I need to do something? Well, let's see. Is there a midline shift? Yeah, there is. So this is a pretty big one. So this person's going to be having symptoms of increased pressure. I'm going to need to evacuate this one. But I see a lot of cases where venous bleeds, they're small. If they're small, you just watch them. Just watch them. They usually regress over time. But this one is so big, this is going to switch their brain. This is not a good thing to have. Not good. Now, here's one of the ways they may test you on this. The CT is a classic way. Show the CT, does the student know what it is? But another way they can do it is like this. Autopsy, we remove the skull. Now you're looking down at my brain. So you're looking down at my brain. So if you look at this picture, here is the skull. It's been cut open. There it is. Here's the skull. Here's where the brain should be, but I can't see the sulci gyri. Because as I look down, what is this thick membrane that's covering up the brain? This is the dura. I can't see the gyri and sulci because it's being covered up by a dura. So if I see blood and then I see dura, this is epidural. So I took up the skull. This is bleeding between the skull and the dura. So this is basically an epidural. By the way, this is a person who fell 15 flights and they landed on their head. 15 stories, they fell. Well, guess what? They fractured both temporal bones, both sides, and they got an epidural on both sides. Well, guess what? Acute bleeding on both sides, what does that do to your brain? You like instantly herniate. So within a few minutes of lying there on the ground, they're basically herniated. So this is one of those herniations that goes right into the tonsils, go right into the, stop breathing right away. So heavy head trauma, that can kill you right away. All right, now let's take a look at this one. Do you see the blood clot? Do you see the brain? Do you see the gyri and the sulci and the gyri and the sulci and the gyri and the sulci? So that means the dura has been removed. So that has to be a subdural. See that? Subdural. Blood sitting on the brain. It's on the arachnoid. It's sitting right there. That's cool. So that's how you're going to tell them apart if they show them grossly. Look to see, is the dura there or not? Is the dura there, or has it been removed? If it's been removed, it's subdural. And that's what this is. And of course, they won't ask you what it is. They'll show you this and say, what rupture? Bridging veins. What was the risk factor? Brain atrophy. So senile atrophy, Alzheimer's atrophy, something made the brain shrink. So that way you stretch these and then you bump your head. And by the way, once you get a subdural, you usually get them again. Why do subdurals recur? Because once your brain atrophies, it's always atrophied. So every time I bump my head from now on, I'm going to get a subarachnoid hemorrhage. Make sense? Makes sense. All right, we're going to end right here. Now, when we come back next time, we're going to talk about 2 more bleeds in the brain. So we talked about subdural and epidural. We need to do subarachnoid, which is bleeding right on the very surface of the brain. And then we need to talk about bleeding intraparenchymal, intracerebral, in the brain. And of course, that's going to be the worst. What do you think the lucid interval is? Well, let's see. For subdural, it was 24 or 48 hours. For epidural, it was 1 to 4 hours. So bleeding your brain, actually in the brain, maybe half an hour. Half an hour and you're unconscious and dead. Not much time for intracerebral bleed. So intracerebral is usually really bad. Okay, so when we talk about strokes, we're going to talk about hypoxic ischemic strokes versus hemorrhagic strokes. And hemorrhagic strokes are less common, but man, they kill you because arterial bleeding makes you herniate. Within 15, 20 minutes, you get symptoms, you're going into coma, and then you're herniating dead in half an hour. So not so good. I don't want to have any bleeding in my brain, but certainly not intraparenchymal, not inside the brain, not good. Okay, I'll see you guys on the next tape, and we'll do strokes. See ya.